So, at the outside, we would like to thank Novartis for this symposium. I think all of you can see my screen. So now, so what we are going to do in the next 20 to 25 minutes is we will discuss some of the issues with regard to the HR positive, HER2 negative metastatic breast cancer specifically. And if you have been following the meeting, many of these issues might be, some of these questions might be repetitions. And wherever you think there is a repetition, let us conclude without discussing further so that we will save time for the next line of treatment options to discuss. So coming on to this, the first question. So my first question is to Dr. Prasad. Can you please take this question? That what is your first line treatment for ER positive, HER2 negative metastatic breast cancer, and in general? And in particular, is there any difference of your approach if there is a visceral crisis or not?
Before we started on with the CDK4/6 inhibitors, we were forced to do chemotherapy in almost majority of the patients when the volume is high on a PET CT scan or imaging modality. But after the 4/6 inhibitors had come to market, we are now feeling very comfortable starting on with the aromatase inhibitors with the oral CDK4/6 inhibitors. Though patients have a high volume of disease, they are still are manageable, and we could rarely see a very good benefit with the oral medications. And by about 2 to 3 months, by the time they are due for the next follow-up, we could see a significant response in many of the patients who have a metastatic disease. So most of the patients prefer oral formulation. They feel comfortable looking at the quality of life, and with the amount of response that we could see with these novel molecules, I think most of us would have changed to AI with the CDK4/6 for the first line treatment.
Sure. So as was discussed earlier also, even in the presence of this, what is called a so-called visceral crisis, we are seeing good responses as early as 6 weeks to 8 weeks.
Yeah.
So I think all the panelists, I would agree with this, and if anybody has any comment, we can make. Otherwise, I would, Dr. Vinay, can you take this question? In a metastatic breast cancer setting, so what is your take on this endocrine resistance? There could be two things. Patient is already a metastatic breast cancer, started on some line of first line aromatase inhibitors, or the patient could be on adjuvant AI with tamoxifen and then develop metastasis. So what is your choice of therapy? What are your thoughts, Dr. Vinay?
So as we know, the options are very much same. But the concept is that there is endocrine resistance whenever it recurs within 12 months of stopping endocrine therapy, which doesn't happen in our practice actually, or patients on treatment or within 12 months of stopping progresses of. This is biology is very aggressive. For our patients we go AI plus CDK inhibitor. It doesn't matter for us because we would offer them that CDK inhibitors upfront. Apart from this, I would do additional testing for PI3 kinase or ESR mutation analysis if possible. Otherwise, I would go for if they don't have visceral crisis, I would go for AI and CDK inhibitors. If patient cannot afford, I would not just only put AI inhibitors. I would add AI plus fulvestrant based upon the data which is recently be there. That's it.
Fine. So, any difference in approaches? Any of the panelists? Okay, fine. So if there is, I think all of us would agree with this approach. This is what all of us do in clinical practice, and which is backed by good data, which we have been discussing all this while. So I would move on to Dr. Pankaj Goyal. Dr. Pankaj Goyal, so when we are considering the treatment in metastatic breast cancer in this setting, so what is it you want always, or maybe is there any preferential thing you are looking at PFS in one time or OS in some time? And all of the above, and what is your thought about it, Dr. Pankaj Goyal?
Yeah, yes, so thanks for the question. Well, if you look into the overall, look into the endpoints in a metastatic disease, you would consider overall survival and quality of life being the prime endpoints. The other two, PFS and adverse effects, are just surrogates of these two major endpoints. It is how long we live and how well we live.
So I think all of us would agree with this, and of course there can be some situations where we want faster responses, and then we would look into like dissect the data as to which drug is providing us faster benefit or something like that. But overall, I think this is what we know about. And the next question also is for, please take up Dr. Chandrika. So this is what the curves we have already seen, the PFS benefit which has been provided in all the three CDK4/6 which are available. They do provide a good PFS benefit for all these patients, and also as my previous speaker has mentioned, the overall survival is also shown by at least two of these CDK4/6 inhibitors, if not all. And very soon, I think we would like to see the third one also. And Dr. Chandrakant, so this is something which keeps occurring in, at least in some patients where the menopausal status, is it really required when you, does it matter actually when we think about treatment in this setting?
Yeah, definitely. Menopausal status helps us to choose the endocrine therapy we use. If you're using an endocrine partner, either AI or fulvestrant is reasonable. However, we use it with ovarian function suppression. If you look into the CDK4/6, we have Monalisa 7, which is addressing the specific subset. And if you look into the premenopausal women, the MCBS score is the maximum for the premenopausal subset. So with this in mind, where we have Monalisa 7 being there, I would tend to choose ribociclib among the other two in this setting, some sort of a marker to select a CDK4/6.
Sure, I think all of you would agree with me, and by now I think all of us have a handful of experience in using the CDK4/6 inhibitors in pre and perimenopausal women also. And I think all of us are kind of convinced of the data which has been shown not only by the Monalisa 7 but also in our own clinical experience. So that is what we wanted to show with this kind of a study. And as we see with in combination with fulvestrant, and we have already seen that all the three CDK4/6 inhibitors do produce a significant PFS benefit, and their efficacy is good, and this has already been addressed. So now the question, Dr. Kaushal Patel. So do you think all these three CDK4/6 inhibitors are still the same, at least by the efficacy is what is shown?
Yeah, to a certain extent, there are the two answers for this question, yes and no, both. Because we have seen the PFS as well as OS data of the ribociclib and PFS data of all three data studies. No doubt the result is different, but to a certain extent, we can say that all three CDK4/6 inhibitor to a certain extent they are same. But if we see the patient populations, then and utilizations of the drugs, sometimes it is a different. Like we can say the abemaciclib is quite useful in the patient who having a brain mets and liver disease, liver metastasis. It is quite effective. It can be used also single agents. It is to be used as a continuous therapy compared to the other two CDK4/6 inhibitor, which has 21 plus 7 gap. Along with that, we have difference in side effect profile also. So we can say in our clinical practice, all three CDK4 inhibitors are not same in all aspects.
Yeah. So I think as the continuation of the discussions which were going on before our symposium also, that we are trying to understand that all the three CDK4/6 inhibitors may not be the same, but however in a poor prognosis kind of a setting, we already have some data, and then subgroup analysis even in the Monalisa trials will show that the presence of liver metastasis side effect also does well, and we know the data of abemaciclib as well. So can we ask Dr. Shivam, so what do you generally do in clinical practice after a patient progresses on a CDK4/6 inhibitor? Dr. Shivam, you are there?
Yes, sir. So I would screen this patient for PI3K mutation, ESR1 and PI3K mutation in my clinical practice. And because majority of these patients would harbor a PI3K mutation, that's what I do.
Okay.
And depending upon the severity of progression, till the time reports are awaited, put them on a brief chemotherapy, or if the PI3K is positive, go for a PI3K based therapy.
Fine. Dr. Pankaj Goyal, did you join or he is not yet joined?
Yeah, I'm there.
Yes. So what is your approach when somebody progresses on CDK4/6 inhibition, Dr. Pankaj?
So we have to see the underlying comorbidities in this patient. If the patient is say known diabetic, not doing well on that, then probably I will not try to fetch an option of PI3 inhibitor. I'll straight off offer something else. If the patient is already on AI for 3 to 4 inhibitors, possibly I'll try fulvestrant. Otherwise, I'll go straight off to chemo. If patient is in good state of health, I know that patient can monitor sugar, so he's not from some remote village. Then I'll go and test PI3K and play around with PI3K inhibitors.
Very good. So did anybody try a single agent edema cycling in this setting? Anybody in the panel? Or what do you think?
I had one patient who progressed in the brain only. So in that patient, I offered abemaciclib. Patient is briefly responding, but I don't know how long this is going to last.
We move on to this concept. After progression on the CDK4/6 inhibitor with an AI, all of us know that this study, which is a widely study, the PIK3 inhibition is a possible approach. So I would like to ask Dr. Prasad now. Dr. Prasad, so when would you like to test a patient with PIK3 inhibition?
Generally, before this thing, alpelisib was launched, we never tested for it. But since the drug is now available, I'd like to test everything upfront. So by the time the patient progresses, at least we will know what would be the second line, and we can be done either upfront or in a state when the patient progresses. Both are feasible. But my practice is to do everything upfront.
Thank you. I think this is what I think many of our colleagues have started doing this. So I would like to now invite Dr. Aparna for her comments on. So what is the ideal tissue which you would require, and what is the PCR, RT-PCR, NGS, or what do you think is the role of liquid biopsy? Aparna ma'am, please can you elaborate on this?
Sure. Good evening, everyone. So if obviously, when there's disease progression, we do recommend going in for testing for PIK3CA. So if you're only looking at PIK3CA, so then you can maybe consider doing a liquid biopsy up front. If tissue biopsy, a read biopsy is not an option. That is something we can consider because liquid biopsy has the chance of actually picking up higher mutations, more mutations versus tissue biopsy. It's slightly more sensitive because it's got a higher depth of coverage. So as long as somebody is using the FDA-approved companion diagnostic kit, which is a TheraScreen, that's what we call this particular kit. If we use RT-PCR for it, it looks at least those very common 11 mutations across 3 exons. I think that should suffice if you're only looking for a PIK3CA mutation. I'm usually in favor of when the disease progresses to go a little bit beyond PIK3CA. I do like looking at the ESR1. I like looking at my ERA status again. I do like doing the tumor biology part of it, but at least as a bare minimum, at least a disease progression. If you have tested your patient upfront, newly diagnosed case, and you have done a PIK3CA, and let's say that's come negative, I would again urge you that when the disease progresses, go back and recheck the PIK3CA. There can be a change. Maybe at that point there wasn't a PIK3CA mutation, and there can be a potential one at progression. So whatever's the availability, but I'm quite comfortable, and I think the SOLO-1 trials also showed that liquid biopsy actually got more mutations than we saw on tissue biopsy. So I like doing liquid. If liquid is negative, then going in for a tissue biopsy, preferably on a newer site. If not, then we can try on the archival tissue.
Yeah. So, I think the very important point here, I think all of us know, is that the PIK3 mutation is a truncal mutation, and which is expected to exist right from the oncogenesis. And that's what. Can I ask Dr. Vinayak now? So, which treatment would you select for patient who is tested as PIK3 mutation positive?
I would go with alpelisib and fulvestrant.
Yeah, so I think the data is clear from the SOLAR trial, the PIK3 mutation testing, and this SOLAR trial clearly showed that the PFS is clearly double. It's 5.7 versus 11 months in patients who are being offered the combination of fulvestrant with the alpelisib. So the problem, as somebody has stated, one of our panelists stated initially, is the comorbidities. And as Dr. Aparna was mentioning, the incidence or the benefit of picking up the PIK3 mutation either in the tissue or in the plasma, it is similar, and so we need not always ask for a tissue, plasma, or a liquid biopsy is equally good. So So I'll straight away go into the point that side effects we know with alpelisib, at least we have a few patients experience that hyperglycemia and rash are the two common things which we tend to notice. So I would like to involve, call Dr. Arun, who is an endocrinologist, experienced endocrinologist treating such kind of patients. Dr. Arun, what do you think the medical oncologist or the patient should be knowing when we are going to start this kind of a treatment?
Yeah, good evening, sir. Thanks for the question. It's very surprising to see the way the patients come with the hyperglycemia. The degree of increase in the sugar is something which we see in patients who are on steroids. So I think it is very important to keep the endocrinologist in the loop from the beginning, and it is worthwhile to have a screening at the baseline, especially the fasting blood sugars and the HbA1c, to know the current status of patient, if he is a non-diabetic or a pre-diabetic, or if he is a diabetic, is he under very good control. As seen in the trials and as seen in the practical scenarios also, we see the hyperglycemia within a week after starting the medication. Sometimes the sugars have gone up way beyond the 250 milligram per deciliter. And I think keeping the endocrinologist in the loop in the beginning of the therapy itself is very important. However, when it comes to the therapy, since these molecules interfere with the intracellular insulin signaling, starting the insulin right away may probably limit the therapeutic efficacy. So choosing those options which are insulin independent, like dietary modifications, regular physical activity, lifestyle modifications, and choosing therapies like low carbohydrate diet, more of a keto diet, and using SGLT2 inhibitors may be of use in these patients to have a good glycemic control, at the same time without compromising the therapeutic efficacy of the molecules which are started with the best intention in these patients.
Yeah, so the issue here comes that we are looking at a patient, somebody who has got a stage 4 breast cancer also. And usually what the intention of a general physician or an internist is to start on insulin when we see somebody in a cancer patient goes with a hyperglycemia kind of a thing. They start on insulin. And we also know that there are some insulin-like growth factors, and that can also lead to adverse events, at least in theory. And yes, I think what about drugs, simple drugs like metformin or things like that?
Yes, metformin can be tried in the patients, sir, but the amount of hypoglycemia can be on the higher side in some patients where, as I said, the sugars can cross up to even fasting more than 250. Fortunately, in the recent past, we've been having certain molecules which function divide of the insulin status of the patient, like SGLT2 inhibitors, which cause glucosuria and give a very dramatic improvement in the blood sugars. So SGLT2 inhibitors in these patients can be of great use. And as said, the insulin can be used as a last resort just to avoid, any kind of therapeutic compromise in the therapeutic efficacy of these molecules. So insulin, I would keep it at a kind of second add-on or a third add-on. I would go for a metformin and SGLT2 inhibitors. At the same time, stress on the diet, little less carb diet and more of a non-carb based diet before I think of giving insulin in these patients.
Thank you, Dr. Arun, because these are very important points that to keep the diabetic endocrinologist in the loop right from the beginning, so that we are relieved and the patients are also relieved of the hyperglycemia kinds of a thing. So my question is now to Dr. Pankaj.
Krishna sir, last 5 minutes to go.
Sure. So Dr. Pankaj, if you want to start somebody on alpelisib, and if you know that the patient is a diabetic, so what is your general approach for this?
One thing is prophylactically anti-allergic has to be, antihistaminics have to be initiated on
We are losing the connection.
patient. And any episode.
Pankaj sir, you can turn off your camera, sir. Pankaj sir, you can turn off your camera. Yes, sir. Now we can hear you.
Yeah, so if for the patient already diabetic, first we have to make sure that the sugar is in normal levels, and it has to be monitored intensively. And apart from antihistaminics have to be given, and I think these patients need to be having some emergency number so that if anything goes wrong, then they can be guided then and there rather than being confused.
So these are the points again for us to remember if we want to manage our patient successfully through the increase the compliance and then manage the patient successfully through this kind of alpelisib. And my question is to now Dr. Kaushal Patel. So what do you think is the role of prophylactic use of antihistamines anticipating a rash induced by alpelisib?
Yeah, absolutely. If we use prophylactic antihistaminic while using alpelisib, then we will definitely reduce the incidence of the rashes.
So this is another important point for us, take home point for us to remember is the use of the antihistaminics in the prophylactic way. And so Dr. Shivam, can you summarize as to your practice, how would you like to improve the compliance of patients to these antihistamines?
So, to start with the compliance, I look at the HbA1c prior to starting the therapy and sort of educate my patients for regular exercise. Then, diabetic management is very thorough. That's one concern, and I'm very keen on reducing the dose of apelacillin. I quickly go to 250 depending upon the toxicity.
But I think that is what all of us have agreed about. Like the first line CDK4/6 inhibitors with endocrine therapy is the standard for most patients with the ER positive stage 4 advanced breast cancers. Consistent PFS benefit we have seen in majority of the randomized trials with all the three drugs. Consistent overall survival is also seen with ribociclib and abemaciclib, and especially post-med, peri and premenopausal women, the ribociclib has shown its efficacy in overall survival. PIK3 inhibitors definitely in the next line where the mutations are detected. Now I think all of us would agree that as we are looking into more and more numbers, we are finding more and more patients with PIK3 mutations, and it is very important for us to monitor the diabetes and then the skin rash. And of course, there are definitely future directions are there where we are looking at the overcoming the endocrine resistance, sequencing treatments, etc. Testing, as Dr. Aparna had mentioned, we would like even the liquid biopsy is good enough for testing, picking up the PIK3 mutations, and if we are going to sequence, then of course the archival tissue or a fresh biopsy is preferred. And I think with this we will conclude the session, and I thank the ISMPO team for giving us the opportunity.